Welcome. Today we're diving into face transplantation, really focusing on the key information you need for severe facial defects.
Exactly. We'll cover the essentials. When it's indicated, the contraindications, risks, benefits, a bit about the planning, and the post-op management. Straight to the point.
Okay, let's start with indications. When do we absolutely need to consider this?
Well, the primary driver is severe facial defects in adults, the kind that cause functional problems, major ones that you just can't fix well enough with conventional reconstruction.
Functional problems meaning?
Things like damage to the central facial structures, orbits, nose, mouth area, structures critical for, expression, talking, breathing properly, eating, controlling saliva, that sort of thing.
And you categorize these defects anatomically.
Yeah, broadly into upper face, lower face,
Yeah.
or the entire face.
And is there a threshold? Like how much loss triggers consideration?
A loss of over 25% of the total facial surface area is a big one, even if a central feature isn't totally gone.
I see. And there's a scoring system, the FACES score.
All right, the Cleveland Clinic FACES score. It helps assess candidates, helps centers communicate. Let's have 5 things: functional status, aesthetic deficit, comorbid conditions, exposed tissue, and surgical history. FACES, FACES.
So those 5 factors function: aesthetics, comorbidities, exposed tissue, prior surgery. They're like the critical puzzle pieces you're looking at.
Pretty much. It's a useful tool for selection,
Yeah.
discussion, but important point, it's not formally validated. So useful guide, but not the final word on its own.
Okay, makes sense. Now let's pivot slightly and talk about contraindications. When is face transplant not an option?
We usually group them into psychiatric, medical, and psychosocial. Psychiatrically, any active disorder, current substance abuse, or if the patient genuinely can't grasp the risks involved, those are absolute contraindications. Cognitive impairment, basically.
Right, and medical contraindications.
Active cancer or a high chance of it coming back, that's a no-go. Also, active infections like HIV or hepatitis, and certain blood or immune system disorders, think hypercoagulable states, lupus, scleroderma, those also rule it out.
What about psychosocial factors?
A solid history of medical noncompliance is a major red flag. You need someone who will stick to the demanding post-op regimen.
Sure, the immunosuppression alone requires huge commitment.
Exactly. Also, not having a good support network is a problem, and pregnancy, obviously. Interestingly, congenital malformations are generally a contraindication here, unlike in hand transplants. Sometimes there was that neurofibromatosis case that highlighted the difference.
Okay, let's talk about the immunosuppression itself. It's long-term, and that comes with risks. What are the main side effects we need to watch for?
Big ones are opportunistic infections. Bacterial, CMV, fungal, especially in the mouth and throat area, or pharyngeal infections are common.
And malignancy risk.
Yes, there's a definite increased risk. Skin cancers, but also virally linked ones like EBV-related cancers, Kaposi sarcoma.
Metabolic issues too, I assume.
Definitely. Hypertension, diabetes, kidney problems, renal insufficiency, or even failure. GI intolerance, too. The good news is many of these can be transient, or at least manageable with adjusting the drug regimen.
But managing those complications is key, because if they get too severe,
Then you might have to stop the immunosuppression. And if that happens, you're almost certainly looking at allograft rejection. It's a critical balance.
what about risks specific to losing the graft itself?
Well, vascular compromise right after surgery is a possibility, though thankfully the incidence is reported as quite low, less than 4%.
But it can happen.
It can. And then there's irreversible rejection, either acute or chronic, leading to graft loss. Trying to salvage a failing transplant is also incredibly tough. These patients have often had many previous surgeries, limiting options for further reconstruction if the transplant fails.
And mortality, sadly, is a possibility too.
Yes, though rare. There have been cases linked to things like medical noncompliance, leading to complications, or severe events during reoperations. It underscores the seriousness of the undertaking.
Despite all these significant risks, the potential benefits must be substantial. What are they?
They really are. Function is key. Regaining oral competence, being able to chew properly that improves eating, controls drooling.
Huge for quality of life.
Absolutely. Also, restoring ocular protection if the eyelids were involved. Enhancing social communication, being able to show facial expressions again, improving speech.
Then sensation.
Yes, return of sensation is another major benefit. All these things contribute massively to functional recovery and, crucially, social reintegration.
Okay, let's get into the surgical planning. How do you design the allograft?
It's totally bespoke, tailored to exactly what functional and aesthetic units the recipient is missing. Functionally, this means planning the bony cuts the osteotomies to match the missing bone structure.
Like using Lafore patterns for the midface.
Exactly. Lafort lines often guide midface work. For the mandible, it might be a custom fit for smaller defects, or maybe bilateral sagittal splits for bigger ones. We use CT scans and virtual surgical planning extensively for this.
And besides bone,
The graft includes the facial muscles, the mimetic muscles, plus the skin and the lining tissues like lips, buccal mucosa, the nose lining.
how do you ensure blood supply to such a large piece of tissue?
The entire facial VCA vascularized composite allograft, including the bone and mucosa, is typically perfused by the external carotid artery and drains via the external or internal jugular system.
And often just one side is needed.
Often, yes. Unilateral perfusion can be enough because the face has such rich collateral blood flow. It's quite remarkable, actually.
That robustness is key. What about nerves? Reconnecting them must be critical for function.
Absolutely.
Yeah.
We focus on the facial nerve for movement and the trigeminal nerve for sensation. For the facial nerve, you want to coapt it as close to the donor muscles as possible. That helps minimize synkinesis.
Synkinesis being those unwanted linked movements like eye twitching when smiling.
Precisely. Depending on how much nerve the recipient has left, we might need to harvest the donor's entire facial nerve trunk, maybe even including the parotid gland to get enough length.
And for sensation, the trigeminal.
We target its branches. Sometimes we need to make specific bone cuts on the donor side just to get longer nerve segments for connection. And you have to remember, sometimes the recipient's sensory nerves might be completely gone from the original injury.
Right. Let's talk preoperative evaluation. What's involved in the medical clearance?
It's thorough. Full physical health screening, assessing overall well-being. Can they tolerate a huge surgery, long-term immunosuppression? Infectious disease screening is vital too, checking past exposures, current colonization, to gauge the risk of opportunistic infections later.
And the immunologic workup, ABO, HLA.
Yes, standard ABO blood typing, plus HLA typing, the tissue matching. We also check for panel reactive antibodies, or PRA. High PRA means the patient is pre-sensitized to many potential donor antigens, which increases the risk of hyperacute rejection and might even be a contraindication.
So HLA typing is like checking the genetic fingerprints to minimize rejection risk.
That's a good way to put it. Minimize the risk of the body attacking the new face.
Psychiatric and psychosocial evaluations are also mandatory, aren't they? What's the focus there?
Huge focus. We need to rule out active psychiatric disorders, assess their likely compliance with the complex medical regimen that's crucial. We also need to be sure they understand the procedure, the risks, and have realistic expectations.
And assessing their coping skills and support system.
Essential. How will they cope post-operatively? Is there a risk of psychological regression? And crucially, what's their home support like? Do they have people to help them through recovery? Assessing that psychosocial piece is incredibly complex but vital.
What about OT and PT? What's their role before surgery?
They evaluate the patient's suitability from a rehab perspective. They might even start some prehabilitation exercises, especially for speech and swallowing, to get them ready for post-op therapy. They also gauge the likely need for PT afterwards and, importantly, assess the patient's motivation and ability to actually participate in therapy.
Makes sense. And imaging. What modalities are critical?
CT scans, definitely. With 3D reconstructions and CT angiography to see the blood vessels clearly. MRI is also used. This imaging is indispensable for really understanding the defect, what's missing, what's still there, and for mapping out those vessels for the anastomosis.
And I understand cadaver trials are part of the prep.
Yes, multiple staged cadaver dissections and simulations. They're critical practice for both the donor procurement and the actual transplant procedure, fine-tuning the technique before the real thing.
Okay, let's walk through the transplant operation itself. 2 teams you mentioned.
Right. 2 surgical teams working at the same time. One procures the graft from the donor, the other prepares the recipient.
What happens on the donor side?
Donor gets a tracheostomy first.
Yeah.
A key point. If the donor becomes unstable in any way that might risk the solid organs, heart, lungs, kidneys, the lives, then the VCA procurement stops. Solid organs take priority.
That's important.
Very. Then the face graft is procured, classified as partial, mid-face, or full face, depending on what's needed. Afterwards, a silicone prosthesis is placed on the donor for cosmetic reasons.
And on the recipient side?
Also a tracheostomy. Then the team essentially recreates the defect by removing any previous reconstructions, skin grafts, flaps, etc. Then they carefully identify the recipient blood vessels' branches of the external carotid, the jugular system that will be connected to the graft.
And the sequence of the actual transplant once the graft arrives?
First, the vascular connections, the anastomosis to get blood flowing into the graft, then bony fixation, securing the skeleton. After that, repairing the inside of the mouth and mucosal linings, then the nerve connections neurography, and finally, closing the skin and other soft tissues meticulously in layers.
Let's cover immunosuppression again briefly. Induction and maintenance.
Right. Induction starts before the transplant hits the OR to prevent immediate rejection. It usually involves a potent drug to deplete lymphocytes like antithymocyte globulin, ATG, or elimtuzumab, which targets CD52.
Plus other agents.
Yes, usually an anti-IL-2 antibody, a calcineurin inhibitor like tacrolimus, an anti-proliferative like mycophenolate mofetil, MMF, and steroids. It's a heavy initial hit.
And for maintenance, long term.
Typically settles down to a three-drug combo: corticosteroids, tacrolimus, and MMF. That's the standard maintenance for most patients.
What about outcomes? What's typical functional recovery like?
Sensory recovery usually starts showing up within about 6 to 8 months. Motor recovery movement takes longer, it's more protracted, but most patients eventually regain good control of secretions, can eat reasonably normally, and manage their airway.
And the social aspect.
That improves significantly too, alongside function, better speech, the return of some facial expression. It all helps hugely with social reintegration.
But complications remain a reality. What are the common ones post-op?
Infections are definitely up there.
Yeah.
CMV, herpes viruses, fungal infections. We manage these with antivirals like ganciclovir or cyclovir, and antifungals like fluconazole, voriconazole, tetraconazole. Prophylaxis is key too.
Metabolic issues we touched on.
Yes, things like high blood sugar, raised creatinine indicating kidney strain, high cholesterol need close monitoring and management.
And rejection. You mentioned it's almost universal to have an episode.
Almost everyone experiences at least one rejection episode, yes. The skin is the most immunogenic part of the graft, so it's often the first place you see it, sometimes the most severe.
What does rejection look like?
Clinically, you might see diffuse swelling, redness, maybe a rash on the skin. You can also get lesions inside the mouth or nose and mucosal surfaces. We use the Banff classification, grading biopsies from 0 to YV based on what we see under the microscope with H&E and PAS stains.
How do you treat rejection?
First line is usually adjusting the tacrolimus levels, maybe adding topical steroids or giving a pulse of high-dose IV steroids. If it's more severe or doesn't respond, then we might need stronger agents like thymoglobulin or elimtuzumab again.
Finally, are there still controversies or areas being actively debated in this field?
Oh, absolutely. Several things. Should we transplant blind recipients? That's a complex ethical discussion. The issue of transferring the donor's appearance mostly thought not to happen significantly with soft tissue, but maybe more of a consideration with big bone reconstructions like after ballistic injuries.
Right.
Combined transplants, like face and hands. Developing protocols to induce tolerance, maybe reducing the need for lifelong immunosuppression. That's a major goal. Whether face transplant should ever be considered first-line therapy. And even technical debates about how much native tissue to keep versus remove for the best aesthetic result. Lots still evolving.
It's clear this is an incredibly complex field with profound implications for patients. A powerful tool, but one requiring immense care and consideration at every step. Thank you for walking us through all of that.
My pleasure. It's a challenging but also incredibly rewarding area of reconstructive surgery.